So welcome everyone. I'm Jen Farmer from the Friedreich Ataxia Research Alliance, and I'm joined tonight by my co-moderator, Kellen Madden, who's our Director of Patient Engagement. This is the last of our community webinar series for 2025. Our discussions tonight are going to be about the cardiac disease of FA, the symptoms, the management, and the research. And we have several special guests with us who I'll introduce you to in a minute. First, I would like to thank our community education series sponsors. All of these sponsors have helped us in support of the webinars as well as our in-person education events. So those regional research receptions that we were able to host throughout the year. So thank you to all of our biotech and industry partners for your support. And then tonight, Kellen and I are joined by several guest speakers. We have Dr. Kimberly Lin, who is the Associate Professor of Pediatrics and Cardiology at the Children's Hospital of Philadelphia. Dr. Mark Payne, Professor of Pediatrics and Cardiology at Indiana University School of Medicine. Max Lim, Associate Professor at St. Vincent's Institute of Medical Research, and Dr. Arti Patel, who is the Associate Professor of Medicine at the University of South Florida. We've got a great agenda with all these speakers lined up, and I'll take you through that in a minute. But before I do that, I just want to tell you a little bit about some of the work FARA has been doing this year. You'll get to hear from some of our speakers about some of the research we've been able to help co-sponsor and fund. But we've also been focused on some cardiac education initiatives, and that's part of why this webinar has been in our series. It is one of the culminating factors of our education series for the year. But we started the year off by hosting a focus group with individuals living with FA and parents to learn more about how FA cardiac disease impacts their quality of life. That has been especially informative to us in thinking about what kinds of education we need to work on. For example, we just completed, Kellen worked really hard on this to bring forward an emergency room pamphlet, something that folks are able to carry with them easily. You can hopefully, print this out. You can hopefully keep it like in your phone or something like that. It has a way for you to easily put in all of your medical information, and then it links to important information for ER doctors about clinical care guidelines and basic information about FA. We are going to continue cardiac education as a priority into next year. And so look forward to being able to bring more resources forward to the community to help with cardiac disease education and awareness and hopefully improve management and outcomes. So tonight, in our webinar, we've kind of got we're going to split it in half. The first half is really about the cardiac disease of FA, the symptoms, the clinical management. We're going to pause after some overview discussion from Dr. Payne and Dr. Lin. We'll do some Q&A. And then we're going to switch gears and we're going to talk about, okay, what kind of research is going on to better understand the cardiac disease of FA? And there, Dr. Lim, Dr. Patel, Dr. Payne, and Dr. Lin will all talk about research studies that's ongoing. Really trying to fund more FA cardiac research has been a high priority for FARA's research team, and hopefully you'll get a good glimpse of that this evening. So with that, Dr. Payne, I think I'm turning it over to you to start us off with the clinical symptoms and clinical management.
All right. Good evening, and thank you for joining. I'm Mark Payne. I'll talk about the first slide, then I'm going to hand it over to Kim. The heart has a lot of pathology in Friedreich's. Some of you know about it a lot, and some of you happily don't know so much about it because it's not been a problem for you. But in this diagram, you can see a cartoon of our hearts, and many of the problems are outlined here. Atrial arrhythmias, in particular, atrial flutter, atrial fibrillation. They also get supraventricular tachycardia. These are the most common. Strikingly, ventricular arrhythmias, those that come from the bottom of the heart, are pretty rare. Almost all of the Friedreich's hearts have an abnormal EKG. We use that to follow this disease. And the ventricular walls, those are the real pumping chambers of the heart, they get very, very thick in about 50 to 60% of the patients who have Friedreich's. And it's not really clear why they do that. Fibrosis within the heart is a really big problem. I'll talk about that later. Almost all of the thick hearts that we've examined have something called a perfusion reserve defect. That's where the interior of the heart doesn't get as much blood flow as it should. And then other things that are going on include the contractile part of the heart, the mitochondria inside of the cardiomyocytes, those are the pumping parts of the heart. They proliferate outrageously. So that's what makes the heart get really thick in this disease. We'll talk about those as we go through that tonight. And from here, I think I'll turn it over to Kim. Are you there?
Here I am. Thanks, Mark.
Thanks, Kim.
So again, my name is Kimberly Lynn. I'm a pediatric cardiologist. I do have the privilege of seeing a lot of patients, both young and older, with FA who have varying degrees of heart involvement. So I'm going to keep this very broad and general in terms of the overview of FA cardiac disease, and we will be planning to leave plenty of time for questions. So in terms of how cardiac disease manifests in folks with Friedreich ataxia, there are several terms to be familiar with, and we should go through those in detail. Those being cardiomyopathy, arrhythmias, heart failure, and then a few things that are common specifically in FA are abnormal ECGs and an elevated troponin level. So when we talk about cardiomyopathy, we love big fancy words in medicine, but really cardio is the heart, myo is muscle, and pathy is like abnormality. So really what we mean when we say cardiomyopathy is an abnormality of the heart muscle. And most people with typical onset Friedreich ataxia will develop some degree of cardiomyopathy. The tricky thing about this is that often there are no symptoms of the cardiomyopathy, especially early in the disease course. And so we do have to do certain screening tests to get a sense of how much the heart is affected. And in terms of screening tests for cardiomyopathy, really the bread and butter, the routine test that you'll get when you visit a cardiologist is an echocardiogram, which is really an ultrasound of the heart. We like fancy names again, especially in cardiology. With respect to surveillance or how often you should be checking in with your cardiologist, the guidelines for FA recommend annual or once a year visits with cardiology. That may change over the course of your lifespan, but really the benchmark is yearly. And if we have certain concerns, we may want to see you more often. And there may be points at which it's reasonable to think about less often, but usually it's about once a year. So the second term I wanted to talk about is arrhythmias, and really that means abnormal heart rhythms. In Friedreich ataxia, that's most commonly an atrial arrhythmia, so coming from the top chamber of the heart. And that's in contrast to the most common abnormal rhythms or arrhythmias in folks with other forms of hypertrophic cardiomyopathy, where ventricular arrhythmias are more common. So atrial fibrillation and atrial flutter are more commonly seen in FA, and really ventricular arrhythmias are not as common potentially until later in the course of cardiomyopathy. Symptoms of this can include heart palpitations, which really describes that feeling of your heart pounding, fluttering, or skipping a beat in your chest. They also can show themselves by symptoms such as dizziness, difficulty catching your breath, or discomfort or pain in the chest. The screening test for abnormal rhythms would start with an electrocardiogram. We will either abbreviate that EKG or ECG, depending on you're going with the German spelling or the American spelling. But that's what we mean by electrocardiogram or EKG. And then a Holter monitor is a type of monitor that goes longer than just that 6-second rhythm strip. So we can do those outside of the clinic and have you wear a monitor for any number of days and understand over the course of a longer period of time what your heart rhythm is doing. And with respect to management, the treatment goal for arrhythmias when they're identified is to maintain heart output. As you can imagine, the heart has a harder time maintaining heart output if you're in an abnormal rhythm. And then also we have to think about preventing stroke and preventing symptoms or mitigating symptoms. So treatment can range from using medications to slow or get the heart back into a normal rhythm. It can also include procedures, such as an ablation procedure, wherein a special doctor will use a catheter and enter the heart and find the abnormal pathways causing the abnormal rhythm and use either freezing or burning techniques to get rid of that abnormal heart rhythm. And then other procedures may include device placement, so pacemakers or internal cardioverter defibrillators, ICDs. These implantations may be options for certain folks in certain situations. At the bottom here, you can just see a diagram of a nice normal sinus rhythm, and then an example of one of those abnormal rhythms called atrial fibrillation. So the last term I wanted to make sure we will go over tonight is heart failure, which is a terrible term. But just what I want to own up to and make sure we address, what do we mean when we say heart failure? We really should try to rebrand ourselves into heart success. But we do have this term heart failure. And what we mean by this is, the problems that can develop when the heart's unable to pump blood efficiently. So that can show up as certain symptoms, such as shortness of breath, swelling in the legs, the feet, or other tissues, fatigue, which is hard to distinguish from fatigue of other sources. Sometimes these symptoms of heart failure may be triggered by an event, such as a major surgery, where fluid shifts are very common, or also infection. So those are sometimes points of time where heart failure may become more commonly show up. The screening for this, again, is cardiology check-ins. There are, in addition to echocardiograms and EKGs that we already mentioned, certain labs that may be checked, including a laboratory study called a BNP, or B-type natriuretic peptide. There are also variations on this, such as NT-proBNP, but these are screening labs to help decipher whether heart failure is happening and could be explaining some of the symptoms that show up. In terms of management, first and foremost, we want to make sure we identify and treat any underlying causes, anything that might have tipped someone from being compensated into decompensated and having heart failure. There may be outpatient medications to specifically consider for the heart, and we can go over some of those tonight if that's helpful. Sometimes hospitalization and consideration for what we call advanced heart failure therapies are necessary. And I do just want to say up front that that's a very individualized decision, both on the part of a patient and a family and in terms of the provider team. But advanced heart failure therapies shouldn't be automatically ruled out or ruled in simply based on a diagnosis of Friedreich ataxia. Really, you have to think about whether those therapies make sense for the individual for whom they're being considered. So again, with heart failure, we have to just acknowledge the heart can and will fail in some individuals with Friedreich ataxia. What's confusing is that you may go see your heart doctor or other doctors, and they may say, oh, you had an echocardiogram and your heart function is great. The squeeze is normal. It's great. But sometimes when the heart is very thick or hypertrophied, the resting phase, that phase of the cardiac cycle or the heart's squeezing and relaxing cycle where the heart is trying to relax and let blood in is compromised. And that's called diastolic dysfunction. And that's somewhat less recognized or less easy to see on a simple test like an echocardiogram. Over time, more overt evidence of heart failure may show up on imaging in ways such as a progressive decrease in the ejection fraction, or the EF. We do like to follow ejection fraction by cardiac imaging, such as the echocardiogram or even cardiac MRIs. And typically, for someone with FA, we'd like to see that ejection fraction remain over 50% whenever possible. Again, as mentioned before, we'll follow blood tests and rhythm monitors in addition to imaging of the heart. And as we'll discuss throughout tonight, We really need a lot more research on heart failure specific to Friedreich ataxia. That being said, there are many tested, tried and true treatments for heart failure that we know of for the larger population of folks that often can and do apply for folks with FA. One more word on a special circumstance. So folks will often want to know about pregnancy and the Friedreich ataxia heart. And I just want to say there's no evidence to say that pregnancy specifically makes cardiac symptoms or FA cardiomyopathy worse. In fact, there are some studies out there that have shown that folks with FA can and have gone through pregnancy successfully, meaning they themselves have had a good outcome and also their babies. That being said, pregnancy is a really dramatic change to any human's body, and so there are some specific things to discuss with your physician when you're considering pregnancy. First, most but not all cardiac medications are safe to use during pregnancy, so you should specifically check on these with your doctors. And then also, it's important to see your cardiologist before. And then if you decide that it's safe to do so, more frequently during a pregnancy for monitoring, especially with respect to how your body's handling the fluid shifts and how your heart is performing throughout this body's change. All right, I'm going to turn it over here back to Mark for some additional insights.
Those are really good points, Kim. Thank you. So the first thing to talk about is chest pain doesn't mean a heart attack. Chest pain is a very common symptom in young people. In fact, I'm certain Kim sees a lot in her clinic. I certainly see them in mine. And it's, a teenager who comes in with chest pain. Whether or not they have Friedreich ataxia is almost irrelevant. Chest pain in young people is almost always due to anxiety, to muscle tears, to muscle spasm in their chest wall or the diaphragm underneath their lungs. It is very rarely due to the heart. In FA, it can be due to the heart. It is worth checking in with your doctor. But rest assured, most young people have chest pain secondary to anxiety or muscle spasm. So yes, this will come up for you. You can relax a bit. Coronary artery disease, which is the most common cause of heart attack, is not more common in FA than in the general population. So young people very rarely get coronary artery disease. It's a very special situation when that happens. So that's not first in our mind when we see one of our FA patients with chest pain. Coronary artery disease is not them. During the emergency room visits, know your baseline, and you are going to have to be your best advocate because FA is a rare disease, and you may have shown up at the emergency room with chest pain, and you may have mild elevation of your cardiac troponins. Well, cardiac troponins are what we measure for heart attacks, and all emergency rooms in the world are going to draw blood for cardiac troponins. And if you're having chest pain, whether it's anxiety or not, and you've got some elevation in your troponin, they're going to be very alarmed. Welcome to call us, at least me, and I get calls from the emergency room all the time about this. That's okay. So next time you see your cardiologist for baseline EKG and for troponin studies, copy them down, take a picture of them and put them on your phone so you can have them as a baseline when you go to the emergency room if you ever have to. Remember, EKGs in about 95% of the FA population are abnormal. So if that's your baseline when you're healthy and happy, then if you show that to the emergency room doctor, they'll be okay with it. I believe that's it. Next slide. I don't know if this was supposed to switch back to Kim, but I'll finish it off really quick. The Friedreich Ataxia Research Alliance, in conjunction with Australia, FARA group had also published a FA clinical management guidelines. Shown here is the website, and if you have your phone handy, you can take a picture of this QR code down here in the bottom right. That is a resource for physicians to read and utilize. Jen, I noticed you popped back on, so you probably have stuff to say.
Yeah. Thank you, Mark. Thank you, Kim. the Kellen will also put this website link in the chat for folks during the webinar this evening, so that you'll have easy access to the clinical management guidelines. And I think we're going to move to our Q&A. And it looked like there were some questions coming in. And so, Kellen, do you want to bring forward our first few questions?
Sure. And I think Kim already answered this one in the chat, but maybe we'll just say it out loud for everyone's benefit. But someone's asked for their son who has FA, he doesn't have cardiomyopathy, but he does have the abnormal EKG. Should he still be seeing a cardiologist regularly?
And I can comment on that live also. And thanks for the question. I think P wave inversion is a very subtle finding, but it is a reminder that, the bioenergetics, the way that that the heart in FA receives energy is altered. And sometimes, evidence of heart muscle abnormalities are really, really subtle in FA. We're still learning about like how aggressive to be with medications and such. So I'm not trying to suggest that someone like your son who has only T-wave inversions should be aggressively treated. But I think someone like him should still be seen around once a year to check in with cardiology and to see if there are any changes evolving over time. And so, yeah, the recommendation for annual follow-up, I think, would still hold for someone with only T-wave inversions visible at this point in time. And hopefully it stays that way and nothing else shows up over time, but we don't want to miss it. We'd like to catch it early and make sure we address changes as they come.
The other thing, absolutely right, Kim. The other thing that can pop up are funny rhythms in the heart, especially atrial arrhythmias, and we don't quite understand why those pop up. So being able to pick those up early rather than late is another good reason to be seeing your cardiologist once a year. And we like seeing you. So are there other questions?
There are other questions. This is a really interesting question. Do you think that all patients with FA have some degree of cardiomyopathy, but it's just a spectrum? Or if there are truly patients who don't have cardiomyopathy, do we know what makes them different from patients who do have cardiomyopathy?
That is a very thoughtful question. I'll give an answer and I'd love to hear Kim's. But the gene defect that runs in their brain runs through the heart, runs through the rest of the body. And so our techniques, our technology for assessing the heart is good. It is not sometimes as in-depth as it could be. So my answer to that would be yes, they either have cardiomyopathy or they have the potential to develop cardiomyopathy that we can then see on an echo or an EKG. So it's not something that we turn our back on. There's always the potential for this particular disease, because it's systemic, that the heart could develop something later on. And again, about 40% roughly of Friedreich's patients don't have overt heart disease that you can see based on an echo. But that doesn't mean their heart is home free. So it's always something we want to watch and follow. Kim, do you have any thoughts?
I will echo that sentiment. I do suspect that almost all folks with FA have some degree, and I think the comment that maybe it's a spectrum of degree of cardiomyopathy is probably true. And as I think we'll highlight in the later portion, we really need research to help us to understand better who's ever going to develop a problem, right? Just because they have the diagnosis of FA, can we figure out who's likely to develop a problem with their heart and who's likely to be okay? Even if their T waves are inverted, could we predict who's going to have atrial fibrillation by age 25 or who's going to have any heart failure symptoms by age 30? We're getting closer on that, but we're not nearly where we need to be with respect to being able to predict. I think identifying cardiomyopathy really has to do with the tools we have available. Mm-hmm. And if we used every single tool that as cardiologists we have in our toolbox, I'd say that we see evidence of heart muscle abnormality in almost everyone, but not quite everyone. There are some folks who surprise me. I read a lot of research EKGs, for example, and I've seen a lot of research MRIs come through on folks with FA, and but it's usually the one that sticks out as, oh my goodness, they don't have an abnormality on this test. I wonder if their echo is normal or if their MRI is also normal. Are there any subtle findings that we didn't catch on X, Y, or Z test? So almost everyone with FA has some subtle abnormality that we can catch by cardiac testing if we look hard enough. But not everyone with FA is going to have a significant heart problem. Too many people will, but not everyone. So being able to identify who that is one of our next jobs.
Other questions? I can see in the box below another question that kind of follows up from that, which is a young child, 13 years of age at this point, doesn't really have overt heart symptoms. And someone told the family that they don't have to worry about that. I would caution against that advice. I would suggest that this person continues to need to see a cardiologist on a yearly basis because we don't know the natural history of the heart disease from young to older in life, like 45 or 50 years down the road. We don't know what's going to happen to them. So yes, they need to see a cardiologist at least once a year.
Thanks, Mark. Kind of a similar question. Does everyone with cardiomyopathy get atrial fibrillation, or is it separate from the cardiomyopathy?
It is not everyone. Some people do, and we can't predict that. Kim, do you want to add to that?
Oh, they're not one and the same.
No.
Certainly folks who have a more affected heart seem to be the ones who more often get arrhythmias. But when we in cardiology see someone, for example, with a thick heart, we automatically start thinking about their risk of ventricular arrhythmias. But specific to FA, it does seem that abnormal beats coming from the top chamber are just more common at a point in time where you wouldn't expect as much of it. So I do think there's something intrinsic probably to the atrial tissue in FA. That, again, we haven't identified the specific reason, but not everyone with FA is going to have atrial fibrillation. It's just a higher proportion than we'd otherwise expect.
Yeah, Kim brought up a really good point. The atrial arrhythmias that arise, we don't know if that's a primary event that happens just in the cells in the top chambers, or if it's the reflection of, problems down in the lower chambers of the heart. We really don't know. And that's why I would never say, I'm sure Kim would say this, just because their heart looks normal doesn't mean that we can turn our back on them, because they still have this gene defect and they can still show up with funny rhythms that we need to treat.
There's a question here about syncope, so like fainting episodes, right? This individual said that they had an episode a couple months ago and had to go to the emergency room, and it was determined that it was syncope, and they were wanting to get more information. Is this related to heart disease?
Speak a
You
little
want to
bit
take
to
that
that?
one?
Yep, sure. Yeah. So the syncope is actually a descriptor. It just means that you passed out. The cause of the syncope, I don't know if they described that to you. It sounds like perhaps they determined that this was a passing out episode that was not related to a specific, like, treatable heart problem or a life-threatening problem, since they sent you home. And that is the most common thing that we find in someone who's passed out. We want to make sure we rule out or we don't miss an abnormal rhythm that needs to be identified and treated, or, for example, a heart attack or some acute heart problem that needs to be addressed right away. But I will say, I would expect that syncope is probably somewhat more common in folks with FA and FA cardiomyopathy than in the general population. One of the reasons would come around to the fact that many folks with FA have a thicker heart than most. And they may be, you and they may be more susceptible to fluid shifts. So specifically, like when your tank is empty and you're dehydrated, you may notice that, or your body may notice that more quickly than in somebody whose heart is not thick and therefore is able to relax better and tolerate periods of dehydration with a little bit more reserve. So I can't know for sure the reason for the syncope in the person who commented's case, but the most common cause is what we say like neurocardiogenic or vasovagal syncope. And the best way to try to help prevent that is to maintain good hydration. If you tend to run a lower blood pressure, to make sure you're not low on electrolytes and on hydration, and to make sure you take the time to steady yourself when you have positional changes, even with transfers, right? With a wheelchair, making sure you're giving yourself a good amount of time to steady yourself and your body when you change position.
Absolutely. Hey, we're probably going to have to move on. I see we're there, but there is one last question I think that probably burns on everybody's mind. And this is a good one. Is there a correlation with the number of GAA repeats regarding cardiomyopathy? And the GAA repeats, the direct answer is yes, there is. It's a rough correlation. It is not exact at all. There is sort of a number below which I really don't expect to see serious problems in the heart. I'm not going to give you that number because it will make you anxious. But yes, there is sort of a correlation, but there are so many other factors that go on in this disease that I can see, and Kim will see, one patient who's got a certain number of repeats and has bad heart disease, and another patient who may have more repeats and has a relatively normal looking heart. So there's much going on that we don't understand about this right now. But yes, there is a sort of a rough correlation. Yeah.
Mark and Kim, thank you. If we have time later, we'll go through more of the questions that have been submitted in the chat or the Q&A box. But for now, we're going to switch gears and now talk about some of the ongoing research. And so, Dr. Lim, I'm going to turn it over to you.
Thank you. Can you hear me?
Yep.
Yeah, great, cool. So thank you so much. Good morning from Melbourne, first of all, and I would like to start by thanking FARA for the opportunity to speak today. Let's just switch on the laser pointer. Right. So one of the biggest challenge that my lab is trying to address is the lack of effective treatments for FA heart disease. And this is largely because we do not yet fully understand how the disease develops and progresses, particularly at the cellular and the molecular level. And a major reason for this gap in knowledge is the limited access to the human heart tissue for research. And most medications are developed through animal study using readily available human cells, such as those taken from the skin or the blood, which are not very representative of the heart tissue. So as a result, many treatments do not translate to the same level of success in human as seen in the laboratory experiment. And to address this issue, our approach is to grow human heart tissue in the lab using patient stem cells. And this will allow us to study heart disease more accurately and create more effective treatments. Okay, it's not transition. Right. So, there's something wrong with my slide. Okay. So in our research on FA, we start by taking stem cells from individuals with FA and guiding them to become a beating heart cells as shown in the video here. So this transformation process takes about 3 to 4 weeks. And once we have these beating heart cells in the dish, we can then use them to make a 3D structure that behaves like a miniature beating heart tissue. This will give us a very powerful tool to study how the heart disease develop and progress, and to develop and test new treatments for FA. So although we have made some very significant progress in addressing the shortage of human heart tissue, discovering and developing new medicines can take a very long time, usually can range from 10 to 15 years. And before medicine can reach the patient, it must go through many layers of testing to make sure that it's safe and effective. And sadly, the reality is that out of thousands of potential medicine that are discovered in the lab, only a few have eventually approved for use in the human. So it's a slow and challenging process, but it's important to ensure that every medicine that we rely on is truly safe and helpful. So to speed things up, we are taking a very strategic approach called drug repurposing. So this means that we're looking at existing approved medicines to see whether they can also help to treat FA heart disease. Because these drugs are already known to be safe for other medical conditions, if we can show that they also work for FA heart disease, that means that we can reach this drug can reach patients much faster than developing a brand new treatment from scratch. So we are very fortunate to have support from the Australian Medical Research Future Fund for this project. And our plan begins by screening thousands of FDA-approved medicine to see how they affect the health of FA heart tissue that we generate in the lab. And then from this large group, we will narrow it down the most promising candidate for deeper testing. So there's around about 7,000 FDA-approved compounds. And from this, we have carefully selected those most likely to be relevant for FA heart disease. And in our first stage, we screened about 1,200 compounds, each at 4 different doses and for 4 repeats. And that add up to be about 20,000 miniature heart that we have generated in the lab in this early stage. And here's an overview of the results. And we are excited to see some of the medicine highlighted in the orange here actually can improve the health of the FA heart tissue. And from this initial list, we have shortlisted about 176 compounds for stage 2 screening. And then from there, we narrow it down again to about 40 compounds, which is currently ongoing and should finish early next year. And after that, we're expected to have about 3 to 5 compounds for more comprehensive testing. So in parallel, we also received funding support from FARA to work on another project focused on omaveloxolone, a medicine many of you may already know. So clinical studies have shown that omaveloxolone can help reduce and slow the neurological symptom of FA, but we still don't know much about how it affects the heart of FA individual. So this project aims to understand exactly how omaveloxolone affect the heart of FA individual, and we hope that we will provide important information or knowledge to support a safer and effective use of omaveloxolone in the future. So here is what we have found so far. So this graph shows the health of heart cells from FA individual, which is in red here, compared to those that we generated from non-FA individual. The higher the value indicate the healthier cells. So before treatments, which is circled in red here, the FA heart cells were already shown to be less healthy than the non-FA cells. But the exciting news is that the treatments with omaveloxolone improve the health of FA heart tissue up to a certain dose. Importantly, the amount of omaveloxolone that currently prescribed to patients fall within this protective dose range. So these early results suggest that omaveloxolone may help protect the heart. However, we still need clinical study that specifically tests omaveloxolone on heart function in people with FA to confirm these promising findings. So finally, I just want to thank my team member and all the funding support. Thank you.
Max, thank you. One quick question I had as you were going through the presentation at the end when you're talking about omaveloxolone, it made me wonder, do you plan to test combinations of therapies like omaveloxolone plus some of the hits you get from the drug screen?
Yeah, that's a part of the plan. So we are wrapping up this study looking at omaveloxolone alone. And now we are currently moving on to look at omaveloxolone in combination with other medicine that's either currently been trialed or the one that we found from our drug screening and open for suggestion as well. So if anyone have promising candidates, we're happy to check it in and see what happens.
The compounds that you selected for the screen, did they also include like standard cardiac medications that some people might be taking, like beta
Yeah,
blockers or calcium channel blockers, or I don't know all the terms for
yeah.
all the different cardiac medications, but I know it's always been challenging for us because there haven't been controlled trials of the different cardiac meds to know maybe which
Mhm.
ones we should start with.
Yeah, that's actually the first category that we go for, like those medication that's currently used for treating other type of heart disease. Um, Only a selected few has seems to increase the survival of the cells. Just remember that the first screen is very simple to see whether they're alive, they improve the alive or not. We're not looking at the function because there's too many drugs to screen and we just don't have the capacity to do everything. Um, Most of them either do nothing in terms of survival, but I can't say for the function. But it's very interesting to see some a category of drugs called cardiac glycoside, which is not commonly prescribed for FA individual. They're actually quite toxic to the heart tissue, but to the heart cells that we tested. But I did talk to some cardiologists who specialize in FA. They did say that this is not a medication that commonly prescribed, so which is good to know.
Yeah.
Yeah.
Thank you. Kellen, were there other questions? I don't want to take up all the time.
I think maybe we'll move on to Dr. Patel and then we can take questions after everyone presents. And while Dr. Patel's bringing up her slides, I will address one question, which is, um, can people with FA register to be organ or tissue donors since it seems like heart tissue is valuable to research? And you can. And I'm going to put a link in the chat that describes two different tissue donation programs for anyone who's interested in that. And Dr. Patel, whenever you're ready, you can start.
Perfect. Thank you, Kellen. My name is Arti Patel. I am Associate Professor of Medicine at University of South Florida, and I'm going to talk to you a little bit today about some cardiology trials, specifically one that we have for our families with Friedreich's ataxia, currently being performed at USF. So, as Mark and Kim mentioned, care for Friedreich's ataxia patients is comprehensive, right? So, we work really closely with our neurology partners. We work with our geneticists, specifically cardiogenetics, and then clinical cardiology. We all work very closely in providing exceptional care for our patients with FA and other neuromuscular diseases. But it really is a team effort, and I really applaud, FARA for publishing guidelines and making those available to everyone so that we can bring the expertise of people at the institutions that you're hearing from today to provide better care and disseminate information across, to all of our patients. So the study that I'm going to talk to you about in particular that we have here at University of South Florida is called Mechanisms, Markers, and Risk Factors in Friedreich's Ataxia Heart Disease. And really, as we've learned today, there's a lot of gaps in our knowledge in terms of why some patients will develop heart disease, why others do not. And so, really, the study is trying to capture a lot of information to help figure out some of those questions. So, what's unique about the study that we have? It is a government-funded Department of Defense grant. We are looking at if we can identify early markers of cardiac disease in patients with Friedreich's ataxia, but additionally, carriers. So, carriers would be relatives of our patients with FA, grandparents, parents, siblings. And the reason is, FA is a small population, a rare disease, and we're hoping by being able to evaluate carriers that opens up the pool of information and may give us some clues into who actually develops heart disease. Our study is also unique in that it's a program grant, and is a 5-year study. I'll get into more of what a program grant means, but it it really touches on the spectrum of research in FA. So we have as part of the program grant, we have 4 individual studies, which are shown here in these circles. So the first is the early detection of Friedreich's ataxia heart disease. That's the clinical study. And then we move into how how genes are expressed in FA heart disease. That's the translational piece, moving into the basic science, looking at mitochondrial function, which is a very important piece of understanding Friedreich's ataxia heart disease. And then lastly, moving into machine learning and AI, putting all the information that we get from the other three projects and trying to see if we can expand it and learn more through AI. So for people that enroll in our study, they're, like I mentioned, the clinical piece or the first project is the early detection of cardiac disease in FA. This is where patients will come to University of South Florida. They'll bring their relatives or carriers of Friedreich's ataxia, and we will perform diagnostic testing. They'll get a thorough genetics evaluation, and we draw serum biomarkers. And all of these are collected and then feed into the other aspects of the program grant. Diagnostic testing will include things like an echocardiogram, a cardiac MRI, EKGs, Holter monitors, all the things that you heard that we use to help detect heart disease in our patients. The serum biomarkers are some typical things like troponins and cholesterol panels and things like that, but we've really expanded that to try and get more information about what may help us detect early disease. So we are actually still enrolling Friedreich's ataxia families in our study. We're looking for patients or FA patients and their relatives. Anyone 16 and above can participate, and travel is compensated for all participants for the annual visits, which occur once a year for up to 5 years. So I put the contact information here, and I'll be happy to put it into the chat as well when I'm complete. But if you are already a patient at University of South Florida, or you'd like to get your neurology or cardiology care, maybe we're the closest university to you. We do have lots of other registries and trials that are going on at USF that are listed here. And what's unique about our government-funded grant is that we can pair your visits for some of these other trials and registries with participation in our Friedreich's ataxia heart disease study. So, if you're interested, please contact us. I'll put again our emails in the chat. And thank you again for allowing me to talk a little bit about our project.
Thank you, Dr. Patel. I think we're going to hold questions till the end, and then I'm going to share the slides again. I think, Dr. Lynn, we are back to you.
You have to put up with me a little bit more, guys. I have just 3 slides here to let folks know about research, past, present, and future. That there's a lot we've learned about the heart in FA, a lot we still need to know, and a lot that we are already doing or planning to do. So this slide is not up for you guys to be able to read every single detail, but to say, we do collect a lot of information with your permission about what your hearts look like, and we try to learn from what you're showing us. So as part of the FA natural history studies. Some folks know this as formerly as FACOMS, and that's turned into Unify. There were some Holter monitor data collected at our site in Philadelphia. And with that information, we were able to look at rhythm data from 131 folks with FA. And we saw that even without overt, meaning arrhythmias that people could feel and were affecting them, 70% had frequent extra beats coming from the top chamber that were not yet turning into a true atrial arrhythmia. So that's a lot of supraventricular ectopy or top chamber extra beats. We also found that things like how long someone's had the diagnosis of FA and if they had a lower ejection fraction, those two characteristics predicted a higher burden of those top chamber extra beats or supraventricular ectopy. So there's not a lot that has come of that in terms of what we do right now, other than know that we should screen folks with FA for what their heart rhythms are doing, and we do recommend at least every other year Holter monitors. But that's raised questions that we hope to be able to answer with future studies that are done prospectively. So, for example, how do Holter findings relate to other disease characteristics, such as things we might find on a cardiac MRI? What happens to Holter findings over time? Which people develop more arrhythmias and which folks are just going to have some extra beats from the top chamber of their heart. And does the burden of supraventricular ectopy predict adverse events in the future? Are there events that are captured in folks who wear longer monitors? Because most of the monitors worn in this study were for about 24 hours, sometimes 48 hours. So a lot of information that we glean from already existing information or existing data, and a lot of questions that we decide we need to answer with future studies. And I think you'll hear about another future study relevant to this shortly. The second thing I wanted to mention, there we go, is this FA cardiac natural history research that we've been doing. Dr. Patel already mentioned in her last slide that they are a participating site along with 5 other places in North America where we've gotten together and collected data now on over 115 individuals with FA who have at least 2 echocardiograms available, performed at least 5 years apart, so that we can look at what's happening over time with granularity. So we were able to collect the digital echo images from all the sites and reread them at a centralized core lab. We're looking at things like ventricular thickness, hypertrophy and mass of the heart, how big is the heart, the chamber sizes, the atrial and the ventricular sizes, how well is the heart squeezing, and then how well are newer markers of heart performance like atrial and ventricular strain performing over time. With this study, we already were able to look and evaluate and found that early thickness of the posterior wall, so the back wall of the heart, looks like an independent predictor of major adverse cardiac events in FA. And that's a parameter that we can look at on regular echoes without a lot of special training. It's commonly acquired, and we may be overlooking this as a predictor of who needs more aggressive treatment. So we do need further investigation, further studies of how does the posterior wall thickness affect someone's outcome, but also, is this something we could look at as an endpoint in clinical trials where someone has a new treatment and they think this is going to, help prevent future cardiac events? Well, do we have to do a trial powered for, how many people die of cardiac complications, or can we do a trial that's shorter and shows an improvement in something like the posterior wall thickness and use that as a surrogate for longer term adverse events that we really want to prevent? So this is an example of how current cardiac natural history is being collected and hopefully utilized in the near future to power clinical trials and increase our understanding of how the heart performs over time in FA. Finally, I just wanted to mention that many of us are also interested in promoting heart wellness. There was one question in the chat about what can I do to, prevent heart problems, even if my child or if I don't have heart problems already. And one thing I think we can be fairly confident in saying is that as much exercise as you're able to perform safely from a physical standpoint is good for your heart and not bad for your heart. So we first did some research funded by FARA to try to measure exercise in folks who can't do a typical exercise stress test. And we found out that many people with FA can complete a good CPET, which is a cardiopulmonary exercise test using adaptive equipment that we were able to purchase for our lab. So either a leaning back cycle using the legs, or even an arm cycle so that we can use the upper extremities to test someone's exercise performance and capacity. And there was really good reliability with that test. And so that was able to empower certain clinical trials even to use exercise testing in FA as an outcome measure. We did recently complete enrollment in a clinical trial looking at the effect of a 12-week exercise intervention and a supplement called nicotinamide riboside on aerobic capacity, which is a measure of exercise performance, as well as insulin sensitivity, which is a metabolic marker. Some of you, if you've been going to FARA symposia or flash talks may have heard a little bit about this study. We did submit the first manuscript describing the findings of that study, and that's in review right now. And hopefully there will be more detailed results out in the public soon. But suffice it to say that we were encouraged by the effect that just 12 weeks of helping folks to exercise at home and utilizing a supplement that mimics some of the things that exercise does to our cells was beneficial and not harmful. Finally, I wanted to mention that FARA is also funding a study to help us complete follow-up on people who did this intervention study and see how many of these people continue to exercise even after completion of the clinical trial, and what forms of exercise do they enjoy the most. Is it the aerobic exercise that we were helping folks to do with these recumbent trikes in their home, or is it more of the resistant band exercises that they could do either standing or in a seated position? So again, looking into exercise and promoting wellness for cardiovascular and total body health is something we're very interested in studying in FA. From there, I'm going to go ahead and cede the floor again to Mark, I believe.
Wow, who was that handsome guy on the exercise bike? Man, somebody from TV should hook him up. I was going to talk about three studies very quickly. One was metabolism of the human heart. The reason that we did this study was because it does seem that there are particular stressful events in the life of a Friedreich patient, scoliosis surgery being one of them, where they don't do well. And my question was, is this secondary to metabolism in the heart? Basically, what we found using a clinical tool called positron emission tomography scan is that the patients who have thick hearts, Friedreich thick hearts, do have abnormal metabolism in their hearts. And you can see on the right, there's three panels. The top panel is a Friedreich's patient with a normal heart, sort of on the echo, looked at with a PET scan. The second is a Friedreich's thick heart, looked at on the PET scan. And then the bottom is a normal person who was included as control. And basically what this study said was the Friedreich heart in some patients, about 60% in the study that we measured, and this was a small study, shift their metabolism to preferring glucose rather than fatty acids. And most of us burn fatty acids in our hearts because it's a very rich source of energy. Glucose is not. And so when we see cardiomyopathic patients, for example, in cardiology clinic, in which they are basically using glucose to run their heart, then it rings alarm bells for us. So these patients who have thick hearts and Friedreich's have shifted their metabolism to burning glucose. The question is, can we affect that in a positive way? Next slide. Following on from Kim's talk about Holter monitors, we are starting a new study, heart arrhythmia development in the Friedreich's patient. And it is unknown what the development of these arrhythmias is like in FA over time. These data would help us predict what the natural history of the heart is going to be like, and we can relate that back to other clinical findings like their GA repeats and their thickness. And it will help us understand if new drugs and new therapies that are coming along for Friedreich's are okay, or do they cause arrhythmias or not? So when somebody starts a new drug for Friedreich's and they have new arrhythmias, did it come from the drug, or was that just the natural history of this heart disease? That is crucial to understand so the drug can go to the FDA. Our goal is to survey 600 Friedreich's participants in North America with a 2-week Holter monitor. It's a cross-sectional study, ages 5 years to adults. Going to wear a Holter monitor for 2 weeks. These Holter monitors are very inconspicuous. There's a picture of one on the right. It's about the size of a dollar bill. You wear it for 2 weeks, you peel it off, you drop it in the mailbox and send it off. It's very easy to do. It's multi-site across the United States, the Unify sites and others in North America. It's simple to do. It will not cost anything to the subjects, and you will get a stipend for it. We need you to help us with this study. Spread the word. We will be coming to you. We want 600 of these things in a very short period of time. We will be mailing them out like crazy. But again, they're very easy to wear. For the ladies, you just peel them off and stick them in the right upper part of your chest. For the guys, well, we're going to ask a little more of you because you got to shave off some of the hair right up there. But that's okay. You'll be okay. It grows back. Stick it on really good. We need your help with this. So spread the word. We're going to be coming to you. We need your help. Next slide. I think this is my last slide. Heart failure or heart disease in the resting phase diastole. The reason I did this study was this slide at the upper right-hand part. That was a young man who died with Friedreich's heart disease. The red in the picture is the cardiomyocytes. That's normal heart tissue. The blue is all of the fibrosis within that heart when he died. And that illustrates how bad the fibrosis should get. It should all be red. There should be no blue in it. And the reason this becomes important is the following. Fibrosis is a common finding in the thick Friedreich heart. It gets worse with time. The cause is unknown, but it may be from slow death of the heart cells, and fibrosis replaces the dead heart cells. Fibrosis affects the heart's ability to relax and fill with blood. And this gets back to the diastole that we talked about earlier in the evening. It acts like a belt, so it won't let the ventricles expand to fill up with blood. There are currently 2 lab studies that are ongoing. This is mouse work. Love those little mices. One is to test a drug called ifetroban, which is also in clinical trials for Duchenne muscular dystrophy in the FA mouse heart. On the right, you can see a Friedreich's mouse heart at the top. It's the middle picture. It's all red. There's very little blue in it, and that mouse got ifetroban. Down below was a equally aged mouse at 90 days of age. We got vehicle, no drug. And you can see the massive amount of blue in that heart. That's bad. So treating the mouse with this drug, just putting it in the drinking water, markedly reduced the amount of fibrosis in their hearts. That was pretty exciting. I need to finish this study up. I'm still waiting on some data. The second study is with Giovanni Manfredi in Colombia. Determine the molecular mechanisms that are driving this fibrosis. That will also be very important because we use that data to determine are there targets we can hit for therapies. So I'm going to stop there and open the floor back up to any more questions and answers. Thank you.
Thank you all so much. We're really grateful for so much cardiac FA research ongoing. Kellen, I'm going to turn it over to you. I know we're a little bit past 8, but I think we could go another 5 minutes or so and answer some questions.
That works for me. We have gotten a good amount of questions. I think this one I'll read first is probably in relation to the study going on at USF that is involving carriers of FA as well. Do we know if carriers of FA have a greater risk of developing cardiomyopathy?
That has not been the case that I've seen.
Yeah, that's true. We don't know that yet, and I think that's part of the usefulness of the study is to try and evaluate if there's, any risk factors for our carrier patients, but also vice versa. Is there something that we can detect in our carriers that may help us identify those patients at higher risk? So we hope to find out more.
Thank you. And maybe while we're focusing on your study, someone also asked, how many family members can you see in the clinic on one day? And specifically the study is looking for one person with FA and 2 family members. Is that right?
Yes, we will see as many want to come. We will accommodate. Normally, the the studies do not all occur on one day. So we will have the families come, and they usually will stay with us over 2 to 3 days just to organize all the testing and get everything that we need.
Thank you. All right. Mark, I think this is a question for you. For the Holter study, is that going to be just in the US, or can it be for people who live outside of the US as well? And this person is specifically asking about New Zealand.
New Zealand. I'd be happy to come down there and deliver you a Holter monitor and bring my fly rod with me. But the company will not let us go outside of North America. And that has to do with European laws regarding clinical studies being different than they are here. So no, I can't go outside the USA and Canada.
All right. I'm looking back. I don't know if, let me look in the chat as well. I don't know if there are any questions related to any of the research projects. Jen, I don't know if you had any follow-up questions for the researchers as well while I look.
I am just also trying to help scan through real quick. It looks like we got, I think, to most of the topics that were in the chat.
Okay.
So maybe just one final question. I know this is, one impression I had kind of listening to all of the research ongoing is that, it seems like we are really at this intense point of trying to gather a lot of information. We know the heart is affected in FA, but what I hear from all of your research is that we still don't know we don't know the ways to predict it. We don't fully know why people get cardiomyopathy in FA, and we still don't have sort of ways of knowing what treatments are going to be the best, and so it sounded to me like we are just in a really big phase of gathering as much information as possible to try and lead us towards those treatments. That was kind of my takeaway. But I'd ask you if you have other takeaways, things you'd like people to leave with in terms of impressions for where we go from here.
I can just start, Jen. I think you're right. We're in a big discovery and information gathering phase, but I also don't want folks who are living with FA right now to despair that we don't know how to take care of folks who have heart disease. I would love to be able to tell you soon that we have FA specific treatments for the heart component, and also like we can identify who we should use treatments on early and prevent heart problems from coming up and we have ways to do that. So those are shortcomings for sure. But for folks who do develop heart disease and FA, similar to other folks outside of the FA community who have heart disease, we have effective treatments and we can take care of you. So I just don't want you to think that because we don't fully understand the underpinnings and have FA specific treatments, that doesn't mean that we're not here in the cardiology community to take care of you and take care of any symptoms that show up and be there on the journey right along with you.
Kim, thank you. That is a really important point, I think. And, Dr. Patel, I think I remember on your slide, you even have some interventional trials going on trying to address the cardiomyopathy of FA as well, right?
Yeah, and I really echo what Dr. Lynn said is that, I encourage my patients as we are on this journey with them in monitoring their hearts that we like to stay open to treatments. There are some general treatments for heart dysfunction that we know are effective. And, I encourage my patients to stay open to those therapies. And, there's very particular regimens for who's may benefit from them depending on how they respond to medication. So we can tailor treatment to individual patients. So I just, as we are on this journey with our patients, just to stay open, and we're here to help guide you through the current available treatments.
Someone had
Thank
asked
you.
about whether even patients without cardiomyopathy but have FA are eligible for trials. And I just want to say in short, yes. Some of the trials are specifically going to be for folks who are very affected. But on the other hand, we need to learn why some folks seem to be more affected than others. So we want to include folks, for example, in the cardiac natural history study, who have the widest range of heart involvement. So yep, we're gonna study both those with and without a lot of heart involvement. And I don't know, Arti, at your center if there are specific trials that someone without cardiomyopathy should be looking at, but there are trials for both types of folks.
Yes, and we encourage specifically in the government-funded DoD trial that we will take patients who have no heart disease, that maybe they have a subtle finding on their EKG, but we're following them over time. And this gives us an opportunity to see who may develop it, maybe why you don't. I think just as powerful as knowing who may develop it, what are those protective factors that mean someone may develop it or a less intensity. So if you don't have specific cardiomyopathy or cardiac dysfunction, we would love to still enroll you in our studies.
That made me think of one thing back to Max, some of your research. You talked about like developing these organoids from skin cells from people with FA, and like over 19,000 different organoids now you've had to grow to do all the screening. But I wondered if even in those organoids from different people with FA, do you see differences in the organoids the same way we see differences in the heart?
Yeah, definitely. We actually working on 3 cell line that provided by Merrick. So all 3 cell line have 3 different GA repeat, and some of them are derived from individuals that haven't developed FA heart disease, and we can see some subtle difference. But because our sample is quite small, so I don't have the power to say, okay, this is definitely associated with some genetic abnormality, but we definitely see some subtle differences. Yeah, but we require a bigger sample size to really answer the question more accurately.
Well, thank you. I'm forever going to have a mental image now of your lab with like all these little organoids and dishes and
It
an
was a big
assembly
challenge.
line of them.
Yeah, so it was a big challenge. But what we have done is that we work with another institute, so they use robotic instrument to help us dispense the cell because it's impossible for us to do this manually. So I mean, our figure will drop off if we do that.
That's cool. Thank you. Well, let me take a minute to thank all of our speakers tonight for taking the time to present and share information on FA cardiomyopathy. And especially thank you for all of your work in the lab and in the clinic, helping to care for people with FA and cardiomyopathy and helping to advance treatments and improve clinical outcomes. We are all incredibly grateful to all of you for the work that you do, and exciting to hopefully have you back sometime next year maybe and hear about how the research is moving along. So thank you all very much. And to all our participants, thanks for hanging in there with us, and look forward to seeing you in the new year. Take care, everyone.
Thank you.
Thanks.
Bye-bye.